Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on assessing candidacy for long-acting ART, featuring Dr. Milena Murray from Midwestern University College of Pharmacy and Northwestern Memorial Hospital in Chicago, Illinois. She'll take us through a case study of a patient interested in long-acting cabotegravir and rilpivirine and explore the latest data and recommendations on patient factors that may inform candidacy for long-acting cab plus rilpivirine as a treatment option. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Murray.
Thank you for joining us for today's topic for key decisions in HIV. Assessing candidacy for long-acting antiretroviral therapy. My name is Milena Murray, and I'm an associate professor of pharmacy practice at Midwestern University College of Pharmacy and an HIV/ID clinical pharmacist at Northwestern Memorial Hospital. Our case study today is a 27-year-old woman who presents for follow-up and asks about switching to long-acting injectable cabotegravir and rilpivirine, which she has heard about. Currently, her therapy is darunavir, cobicistat, emtricitabine, and tenofovir alafenamide. On this regimen, she has been stable for 3 months, and she has no reported side effects. On the right side of the screen, you can see her labs here and other patient characteristics. I want to call attention to the HIV subtype, which is A6, her pre-therapy genotype, which has an E128K, and an N155H mutation, as well as the patient's BMI, which is 32. So our question is, what should we consider when assessing for appropriateness of the long-acting cabotegravir and rilpivirine therapy? Are there any concerns for virological failure? The long-acting injectable combination of cabotegravir and rilpivirine was FDA approved in January of 2021. These medications are indicated as a complete regimen for the treatment of HIV-1 in adults who are virologically suppressed and stable on their current therapy. There should be no history of treatment failure or suspected resistance to cabotegravir or rilpivirine. Before initiating the injections, a month-long oral lead-in is completed with oral cabotegravir and oral rilpivirine to assess tolerability. Of note, these oral medications should be taken with food. Then, on the last day of oral therapy, the initiation dose of cabotegravir 600 milligrams and rilpivirine 900 milligrams, which are given as 2 3-milliliter injections, are given. And then maintenance doses are started monthly thereafter, which are cabotegravir 400 milligrams and rilpivirine 600 milligrams. And this is 2 2-milliliter injections. So what led to the ability to administer these medications monthly? Plasma concentrations of each medication are graphed here against number of weeks. As you can see, the levels are consistent and well above the IC90. Each of these long-acting injectable agents also has a long half-life, cabotegravir with a half-life of 5.6 to 11.5 weeks, and rilpivirine with 13 to 28 weeks. So what do the DHHS guidelines state? They recommend the long-acting injections to be used to optimize current therapy for those who are on oral therapy and have been virally suppressed for 3 months. It is important to note that the optimal duration of virologic suppression prior to switching to the long-acting injectables has not been defined. The guidelines further go on to state that those initiating therapy should have no baseline resistance to either cabotegravir or rilpivirine, have no prior virologic failures, no evidence of active hepatitis B infection, unless they're going to be receiving an oral hepatitis B regimen in addition to the injectables, that they are not pregnant or planning to become pregnant, and finally, that they are not taking any medication with significant drug-drug interactions with either oral or injectable cabotegravir or rilpivirine. The concern with drug-drug interactions for the oral formulations should be considered both for the oral lead-in period as well as any time that potential bridging therapy may be necessary. So let's talk about treatment emergent resistance that has been seen in trials. There were 6 patients total in the ATLAS and FLAIR trials that developed treatment-emergent resistance, 3 in each study, and these are all listed on the slide. It is important to note the similarities in HIV subtype and the resistance-associated mutations, or RAMs. Of note, the L74I is not considered an INSTI-RAM per the IAS USA and should not affect cabotegravir sensitivity. Overall, 101 out of 483 patients had a baseline L74I in the FLAIR study. Of those patients, the majority were subtype A3. In the study, the presence of L74I did not negatively affect the study outcome of HIV-1 RNA less than 50 copies per milliliter at week 48. When the analysis was extended to 96 weeks, there were no additional cases of treatment-emergent resistance. The ATLAS 2M study assessed every other month dosing of long-acting cabotegravir and rilpivirine versus the every month dosing of the medications. There were approximately 500 participants in the 8-week arm and in the 4-week arm. There were 8 virologic failures reported in the 8-week group and 2 virologic failures in the 4-week group. Of these failures, 6 out of 8 in the 8-week arm and 1 out of 2 for the 4-week arm had rilpivirine RAMs. For INSTI-RAMs, there were 5 out of 8 in the 8-week group and 2 out of 2 in the 4-week group. The treatment-emergent RAMs for rilpivirine and INSTIs are listed in the table. The overall conclusion was that the injectables were well tolerated and the patients preferred injectable therapy over oral therapy, and they also preferred 8-week dosing over every 4-week dosing. Now let's look at some data about factors that can contribute to the risk of treatment failure with the new long-acting injectables. A post-hoc study of week 48 data from the 3 phase 3 trials that evaluated cabotegravir and rilpivirine aimed to assess factors that were associated with virologic failure. For each participant, data on the following 10 covariates were collected and evaluated: the presence of the L74I integrase polymorphism at baseline, pre-specified INSTI mutations at baseline, rilpivirine RAMs at baseline, NNRTI RAMs, which excluded the rilpivirine RAM since that was a separate variable at baseline, HIV subtype A6 or A1, female sex at birth, BMI at baseline, the dosing regimen used, and week 8 cabotegravir and rilpivirine trough concentrations. Now, for those who are on the 4-week regimen, they used population pharmacokinetic post-hoc estimates of concentrations 4 weeks following the first long-acting injection so that they had 8-week data for all of the patients. The analysis included 1,039 participants. Confirmed virologic failure was seen in 13, which is 1.3%. The summary of these participants for the previously 10 mentioned covariates is included on this slide. Looking through the variables, several covariates were present in multiple participants. In the analysis, there were 4 factors associated with an increased odds of confirmed virologic failure. These were rilpivirine RAMs at baseline, a log base 2 of post-hoc week 8 rilpivirine trough concentrations, and this is interpreted as each halving of the value, baseline HIV-1 subtype of A6 or A1, and a body mass index of 30 or greater at baseline. In this model, the 8-week dosing was not a significant factor. An analysis per baseline factor revealed that those participants with 2 or more baseline factors listed were numerically more likely to have confirmed virologic failure. Taking into consideration all of the information from the guidelines as well as the data available, on this slide, the left side has the recommendations for each candidate for long-acting therapy. So these are going to include those with no baseline resistance to either injectable medication, no history of prior virologic failures, do not have active hepatitis B infection, that they are not pregnant or planning on becoming pregnant, and that patient is not receiving medications that are going to have significant drug interactions with either injectable or oral cabotegravir or rilpivirine. Overall, it is important to note that confirmed virologic failure with the long-acting agents is a rare occurrence. The data available provide a few baseline factors that may preclude a patient from being a candidate for injectable cabotegravir and rilpivirine. These are proviral rilpivirine RAMs, HIV subtype of A6 or A1, and a BMI of at least 30. It should be further noted that the combination of these baseline factors were uncommon in the entire clinical trial pooled population, as previously presented. So let's revisit our case study. We have a 27-year-old woman who's presenting and asking about switching to the long-acting injectables. She is currently on darunavir, cobicistat, emtricitabine, and tenofovir alafenamide, of which she has been stable on this regimen with no side effects. And again, on the right side, pointing out her HIV-1 subtype of A6 and the pre-therapy genotype of E138K and N155 mutations, as well as the patient's BMI of 32. In the available data, failure was more likely if two or more of the following are present at baseline: the proviral rilpivirine RAMs, HIV subtype of A6 or A1, and a BMI of at least 30. Our patient has a BMI of 32, subtype A6, and the E138K mutation, which confers baseline resistance to rilpivirine. Given this information, there may be concerns of virologic failure if the patient were switched to the long-acting injectables. Thank you for joining me today for this key decision in HIV care. More medical minutes and podcasts, clinical thought commentaries, and shareable patient education sheets are available at clinicaloptions.com/HIV.
Thank you to Dr. Murray, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.